Okay, so today we'll begin with our cases with abdominal pain. First case is upper abdominal pain. So, what are the organs situated in upper abdomen? These are the liver, there is gallbladder on right upper side, and there is pancreas in the epigastric region, and in left upper quadrant there is a spleen. So sometimes a spleen may rupture, or if there is history of trauma or history of past infectious mononucleosis, there may be a spleen rupture. Causes of abdominal pain are those in the right upper quadrant. I mean to say that hepatitis, cholecystitis, maybe the causes. In the epigastric region, if there is pain, then it can be pancreatitis, pancreatic cancer, or it can be gastritis, GERD, or gastric cancer. So, how do you approach, or how do you go on ruling out each? So we have to ask each specific question for each differentials to rule out those. Like for gastritis, what type of food aggravates the pain? Have you used any type of NSAIDs? Is there any relationship between pain and timing of your food intake? Okay, and to rule out hepatitis, you have to ask any change in your skin color. Is there any yellowness of your skin, any distension of your belly? Okay, those kind of things. I'm just talking about history, not going on physical examination. And GERD, have you noticed any burning sensation in your chest, or any abnormal taste in your mouth? And have you ever been exposed to anybody with similar complaint? Like to rule out if there is an infections. Okay, sometimes gastroenteritis may be causing abdominal pain. So you had also to rule out infection. Have you noticed any change in color of your stool, or any blood in a stool? Because in every jaundice cases, you have to ask what is the change, any change in color of a stool, or urine color change. Because this helps to figure out whether it is a I mean to say that obstructive jaundice, or is it a hepatic jaundice, or pre-hemolytic jaundice. That's why. Have you ever eaten anything food outside food recently? So those types of, because of to rule out food poisoning, and that may also cause abdominal pain, nausea, vomiting, diarrhea. And to rule out pancreas problems, any steatorrhea, you have to ask: is your stool difficult to flush? Is your stool foul smelling? No? Do you have diarrhea? Malabsorption. If there is a pancreatitis and the patient has malabsorption, there may be chronic diarrhea. And its typical feature is pancreatic problem, is pain radiating to back and a relieved one bending forward. You have to specifically provoke those questions by asking if there is any pancreas problem or not. Or there may be a belly stone as well. I mean to say that there may be renal stone, or it may be gallbladder stone. So you have to ask any history of, do you have any history of belly stone? And in every cases, you have to ask about any notice. Have you noticed any change in your weight? Because some infections, or as well as mostly malignancy, causes weight loss. So what are the workups that you need to do in upper abdominal pain? If you suspect gastritis, or GERD, or gastric cancer, obviously you have to do UGI endoscopy. Okay, and H. pylori serology if there is suspicion of the peptic ulcer disease. Uh, and a patient is from endemic area. And to rule out pancreatitis, or chronic pancreatitis, or pancreatic cancer, those are the things you have to do CT scan of abdomen. Okay, and for hepatitis, cholecystitis, ultrasound abdomen. And other than that, physical examination is also required. If you suspect there may be blood in a stool, or if you like to do rectal examination, you can write rectal examination if it is relevant to case. And pelvic examination, FOBT, fecal occult blood test. And if you suspect hepatitis, AST, bilirubin alkaline phosphatase. And if there is suspicion of cholecystitis, and if it is not confirmed, then HIDA scan. Those are the things. Now we go on to diarrhea. So what are the causes of diarrhea? If you How do you approach a case of diarrhea? First of all, how I approach is diarrhea acute or chronic? I mean to say that, is it for a long time, like 3 week, 4 week, or is it only for 2 days, 3 days? Because if it is for a long time, you suspect there may be some malabsorption problems, mostly. But there are other causes as well, like but mostly. But if there is acute onset, then you suspect there may be some parasitic infection, or any bacterial infection, or viral infection, or any food poisoning. Those kind of things comes first up in my mind. Okay, so and other thing comes comes in my mind is diarrhea mixed with stool. I mean to say that it's blood or not. If it is, if you see blood in your stool, then it can be bacterial infections, like it can be dysentery, or it can be inflammatory bowel disease, or it is just only diarrhea. Then it can be irritable bowel syndrome, or it can be some types of dysentery. I mean to say that dysentery causes blood in stools, but in pseudomembranous colitis, there can be no blood in it as well. Sometimes there may be blood you can see, but so you have to also ask history of any antibiotic used recently. Okay, and let's go in detail each differentials. So gastroenteritis. So for to tell gastroenteritis, whether he has gastroenteritis not, you have to ask any travel history, any ill contact, like those things. Or so you have to also keep in mind thyroid problems, because if there is hyperthyroidism, that may also cause the liquidy stools. So you have to also keep that in mind. And other infections in general, like HIV AIDS, you have to also keep in mind, because cryptosporidiasis and those many parasites causes chronic diarrhea in AIDS patients. So those are the things. And any absorption problem, you have to also specifically provoke, I mean to say that especially ask questions related to celiac disease or any lactose intolerance, any relationship to special types of foods. Okay. And sometimes cancer may cause diarrhea. So you also have to ask any change in your weight, appetite, like those things, to rule out if there is any malignancy. And I have already told you, discussed previously, that pancreatitis, chronic pancreatitis may also cause a diarrhea. So you can ask by any staturia, any I mean to say that any is your stool difficult to floss, or mm, any foul smelling stool. And for giardiasis, like those things, parasites, you have already told you, travel history should be asked. So when the patient tells you that he has diarrhea, you should ask the consistency of a stool. What does it like, looks like? Is it watery, or is it liquidy just? So, and if there is blood in it, and do you have pain while passing a stool or not? Do you have, or tenesmus, like those things? How do you ask tenesmus? Like it is written that do you have sudden spasm of anal canal followed by sudden urge to go to bathroom? Can also ask, like, do you feel like you have incomplete evacuation of your bowel, or any pain while having bowel? Do you have urgency to go to bathroom to pass a stool, like those things? Because it indicates there is some types of inflammation going on in his, it can be proctitis, or it can be some inflammation, other types of inflammation. And if there is pain, and if there is blood in the stool, then you also consider anal fissure, because that may be the also possibility. But anal fissure commonly occurs in case of constipation. If patient has a long standing history of constipation, then anal fissure lies likely because of the impaction of a stool, and that causes tearing of anal mucosa, rather than presenting with diarrhea. So for watery diarrhea, go on. I have already told you, for gastroenteritis, traveler's diarrhea, you ask any travel history, any have you eaten outside recently. And Crohn's disease may also cause watery diarrhea. So any, you have already told you, like you have to ask in a sense of incomplete evacuation after passing a stool, any pain in belly. For pseudomembranous colitis, any antibiotic use. For hyperthyroidism, do you feel like you have racing of your heart? Have you noticed any skin changes, any tremor of your hand? And for AIDS, to rule out AIDS, any neck swelling, like to rule out lymphadenopathy, and lumps or bumps in your body, or do you have fever, like those things. And for irritable bowel syndrome, any relationship between belly pain to bowel movement, you have to specifically ask this question. Any some patient tells that their belly pain relieves after passing a stool. And any alternating diarrhea and constipation, if patient is presenting with diarrhea, then you should ask, do you have any history of constipation in past? Okay. And for lactose intolerance, any relationship of diarrhea with milky products? For ulcerative colitis, I mean to say that now I'm going towards bloody diarrhea. What are the causes of bloody diarrhea? And first is ulcerative colitis. So any sense of incomplete evacuation after passing a stool? Any pain in your belly? Do you have to rush to defecate? Have you noticed any skin rashes or joint pain? And for dysentery, to rule out, do you have fever? Do you have pain in your abdomen? Do you have nausea? Have you eaten outside? And cancer, you can, I have already told you, you have to notice any change in your weight, any change in appetite. Okay, those are the things. And for malabsorption, I have already told you, I have to ask, is your stool difficult to flush? Is your stool foul smelling? And pancreatitis, what are the causes of pancreatitis? Mostly gallstones and alcohol. So it should also ask any history of belly stone, or do you have use alcohol, like those things. Okay. What are the investigations that we do in diarrhea? So depending on the cause that we suspect, like we can do rectal pelvic examination, we can do stool examination, and fecal leukocytes, and for hyperthyroidism we can do TSH, and we can also do ultrasound abdomen. We can do colonoscopy to rule out if there is any colitis like symptoms, or to rule out celiac disease, anti-trans glutaminase antibody, anti-indomycin antibodies. You may also need to take biopsy of a bowel. Okay, so by endoscopy with biopsy. So these are the investigations that are mostly done in these cases. Now we move towards blood in stool. What are the causes of blood in stools? Let's remember the differential diagnosis. First of all, you have to consider like this way, region wise. For example, if there may be in anal area, there may be hemorrhoid, there may be anal fissure. In colon, there may be colon cancer, there may be diverticulosis, there may be angiodysplasia. In upper part, there may be ulcerative colitis, there may be inflammatory bowel disease, there may be stomach, there may be gastritis, there may be peptic ulcer disease. In liver, may be chronic liver disease, and that may cause variceal bleeding, so that may be the possibility. So when you patient says he has blood in stool, you should ask whether it is fresh blood, or is it black stool, or do you see blood while using napkins while wiping, or do you see blood mixed throughout a stool? So those are the things that you should specifically ask. And do you have pain while passing a stool? And let's go on ruling out each differential diagnosis. Is the blood before mixed or after passing a stool? This is the first question. And then what is the color of blood? I have told you it is bright red or dark color, or and you have also to ask some complaints specific to GI tract, like you have to have nausea, do you have vomiting, any abdominal distension, any abdominal pain, okay, any oral ulcer, like those things. And then let's move forward. And to rule out colorectal cancer, any change in caliber or thickness of a stool. Hemorrhoids, have you noticed anything coming out of or protruding from the anus? And for angiodysplasia, any if you suspect old age and there is painless happy bleeding there, then it may be the possibility that it may be angiodysplasia, or it may be diverticulosis. And so you have to ask, do you have any history of constipation? And mostly patients with diverticulosis, anal fissure, hemorrhoids, these patients, and colon cancer as well, have history of constipation. So it is very important to ask any change in your bowel habit. Okay, those types of things. And for ulcerative colitis, have you noticed a sense of incomplete evacuation even after passing still? Do you have to rush to defecate? Do you have to rush to pass to stool? Have you noticed any joint pain, or a redness of eye, or any skin changes? Okay. Mm, and for chronic liver disease, any distension of your belly, have you noticed any enlargement of your breast, any skin changes, like there may be palmaridema, there may be a spider angioma, okay. And for epigastric pain, you have to specifically ask a relationship between pain and timing of your food intake. For example, in gastric ulcer, there may be pain may be aggravated with food intake, and peptic ulcer disease, food may relieve the pain. And for gastritis, you have to ask like any heartburn or GRD, to rule out any use of NSAIDs. So those are the things that you specifically ask. These are at least these questions. And what are the investigations? Investigations depend upon the what you suspect in your differentials. Like you can do rectal pelvic examination to rule out liver disease, ALTS, bilirubin, alkaline phosphatase, and to rule out peptic ulcer disease, upper GI endoscopy. To rule out colon cancer, you can do colonoscopy, and fecal occult blood test, and ultrasound abdomen, and H. pylori testing. So those are the common investigations we generally do. And then let's move towards abdominal pain. Before moving that, I would like to tell you one thing. Is For example, in GI cases, if patient has abdominal pain, you should specifically ask, is there any relationship of food intake with your belly pain, or is if a patient has diarrhea, is there any specific relationship of any special food with your diarrhea? Okay. And in, for example, in if a patient has chest pain, is there any relationship between your deep breath and chest pain, or is there any relationship between cough and chest pain? Okay, so that provokes something that some helps to reach you some differential diagnosis. So you should ask any relationship between those events. And now let's move to our lower abdominal pain. So what are the causes of lower abdominal pain? There may be GI causes, gastrointestinal cause. There are kidney, so maybe kidney stone. There may be pyelonephritis, or there may be UTI, cystitis. These are the things in related to urinary tract. And in female there may be extra components like their uterus and ovary, like those kinds of problems like endometriosis, adenomyosis, fibroids, and ovary, so ovary tumor, ovarian cyst, torsion, and other thing is that pregnancy, ectopic pregnancy. And in GI causes there may be appendicitis, there may be diverticulitis if pain is located in left upper quadrant, left lower quadrant, or there may be irritable bowel syndrome, or maybe IBD as well, or maybe gastroenteritis. Okay. So let's move. So what are the questions that you need to ask? Do you feel nausea? For GI cases, you should ask nausea, vomiting, abdominal distension, abdominal pain, any change in your bowel habit. Those are the questions that you must ask in GI cases. And if patient has a change in bowel habits, or have diarrhea, have you eaten food outside, do you have fever, have you ever been exposed with similar complaints, I mean to say that any ill contact, okay, and any blood in stools, what sort of diet do you usually eat, and what is the relationship of pain with bowel movement, any pain during night. For example, patient with irritable bowel syndrome does not have pain during night, or does not have diarrhea during the night. So you have to also ask, do you have still diarrhea while sleep, while night, or do you have only daytime diarrhea, or do you have pain during night? Okay, so those are the things to rule out irritable bowel syndrome. And have you noticed any sense of incomplete evacuation, any joint pain, oral ulcer? Those are the things that you should ask to rule out inflammatory bowel disease. And let's move towards genitourinary system. So ectopic pregnancy, ovarian torsion, like those things. So I have to ask, focus on the menstrual cycle, like when was your first menstrual period, how is your period regular, how often does your menstrual period occur, and how long does each period of menses last, and do you have pain during menstruation, and any spotting in between, any vaginal discharge, and how many tampons do you have to use, any dyspareunia, like any pain during sexual intercourse or defecation, or any pain while sexual intercourse, any pain or any vaginal bleeding after sexual intercourse, when was your last menstrual period, are you pregnant, have you ever had abortion. And also you have to ask some screening questions like, when was your last pap smear. So what are the workup that you need to do in lower abdominal pain? In lower abdominal pain, depending upon the suspicious pathology, we do investigations. Like if you suspect there may be some uterine or ovarian component, maybe more likely, then you can do ultrasound abdomen. Like if you suspect there may be endometriosis, adenomyosis, fibroid, then maybe ultrasound abdomen. Maybe need to do a hysteroscopy. Okay, so those are the things. And especially pelvic examination, and beta urine, beta hcg, to rule out if there is any pregnancy. And those are the things. And for GI cases, you have to do ultrasound abdomen again, to rule out appendicitis. You may require CT scan of abdomen, and colonoscopy may be required. Or other than that, AST, ALT, bilirubin alkaline phosphatase, those are the liver function test if you suspect if there is any problem with liver. Okay. And if you suspect other GI causes, like upper, you may also write a upper GI endoscopy, CBC with differential, serum electrolytes, glucose, like those things. These are the common investigation that we generally do in every outpatient visits. And now move to a testicular pain. Testicular pain, what are the cause of testicular pain? So if there is a acute onset, or is it chronic in onset? For example, if it is acute onset, there may be hematoma. In scrotal hematoma, there may be torsion of the testis, or there may be epididymitis, epididym or chytrix, like those things. Or if there is chronic, it may be hernia, or it may be okay. So it hernia may also causes, if it is strangulated, it causes acute pain. So you have to ask, like, have you noticed any anything, any tissue protruding from your lower belly, like those things. If you suspect, to rule out hernia. And specifically, you should ask, do you have any history of trauma to your genital area recently? Have you noticed anything coming into your scrotum? Have you noticed any change in your bowel habits? Have you noticed any relationship of swelling to position or lying down? Okay. Any relationship of swelling to position or lying down? Okay. mm, do you rule out hernia? And have you noticed any burning sensation while passing urine? Do you have to urinate more frequently than usual? Those are the things to rule out epididymitis. And do you have to rush to urinate? maybe infection that may be cause the irritation and burning sensation and more frequency and urgency, like those things. And to rule out orchitis, have you noticed swelling anywhere else in the body, like parotid swelling maybe cause mom's orchitis? And to torsion, have you noticed pain in your belly? Have you noticed your testicle in abnormal position? Okay, so those are the things that you should ask to rule out torsion. And what are the investigations that we do for testicular pain? So Doppler ultrasound pain is to rule out torsion of testis. And first of all you should do pelvic and rectal examinations. Okay, and other than that you can do urinalysis, urine culture for ruling out epididymo orchitis. And you can hematoma to rule out ultrasound testis and abdomen. And if you suspect any infections, then we can do, like for example, if there may be strangulated hernia, CB2 differential serum electrolytes, glucose. Those are the common investigations. And let's move towards knee pain. What are the causes of knee pain? So you have to consider whether it is acute in onset or is it chronic in onset, because it helps to clarify what are the causes. For example, if it is acute in onset, there may be some trauma, or there may be and trauma may cause like ligament injury, meniscal tear, like those things, or it may be some bleeding inside and her knee, in his knee joint as well. And but it is chronic, then we suspect that it may be arthritis, like things like it may be rheumatoid arthritis, maybe osteoarthritis, it may be gout, it may be pseudo gout. Okay, and it may be septic arthritis as well, or SLE may also cause knee pain. So those are the things that you consider. And to specifically ask what questions need to ask, first of all you should follow the Socrates mnemonic, like site and setting. What is the site of your pain? And if you look at on the left side, I mean to say that medial side of knee, then you suspect that it may be some bursitis, like pes incidence pain syndrome is mostly located on medial side of tibia. If you locate it in the middle of the knee, then we suspect some knee pathology. Or if patient sometimes complains that he has knee pain, but he may be having main problem may being calf. So you have to ask those, what is the site and what were you doing when it started? Site and setting. And specifically I remember like this: space and time. Space means what is your site, and setting in which condition it started, timing and duration, for how long you are having, and how is it progressing, and is it constant or intermittent, does it comes and goes. Okay, so those are the space and timing like things. And then we go to onset. I've already told you, sudden or gradual in onset. And Socrates, C for character, it will be sharper or dull pain, like those things. It is most not relevant to ask character in knee pain. And radiation, R for radiation, those are knee pain travel anywhere else, and anything that worsens it, like mostly patient like movement worsens it. So it is also not necessary to ask anything that relieves it. So obviously there may be some pain medications or rest may relieve it. Knee pain, what are the other things that relieve it? Nothing. Okay. And then we go to, I have already told you, and severity on a scale of 0 to 10 we have to assess the severity as well. So and specifically for any knee joint pain, you have to ask any warmthness, redness, swelling, stiffness. These four components you have to ask. And any weakness, numbness, tingling, any discoloration of your fingers, two joints, any discoloration, any skin changes, any hair loss, like those things. And to actually any difficulty tolerating sunlight, or do you feel fatigue, do you have oral ulcer? Okay. uh, these are the things to rule out there is an autoimmune condition, like do your fingers get blue when exposed to cold, any discoloration of your fingers in the cold. And so what are the investigations that you should do? So depending on the cause, like if there is if you suspect that there may be arthritis, or it may be some ligament injury, you can do X-ray, MRI, knee joint. Okay. And if you suspect there may be septic arthritis, there is some infection going on, you can do arthrosynthesis. Or if you suspect gout, pseudo gout, also arthrosynthesis and synovial fluid analysis. Okay. And in septic arthritis we also do a CBC differential. And if patient is old age, you can screen for by doing DEXA scan, calcium, vitamin D. And okay, so these are the more common investigations. Okay, so now let's move towards arm pain. What are the causes of arm pain? Arm pain means upper, you have to specifically ask where is the pain. Is it in the up arm, or is it in the shoulder joint? Okay. So can you please point out the location of pain with your own finger? Okay. And so patient points out it is in an arm. Okay, so you have to make, you may suspect that there may be fracture, or it may be muscle strain. Okay. Or if you suspect that the patient has a pain in his shoulder, then it may be shoulder dislocation. There may be fracture as well of the neck of humerus, maybe rotator cuff tear, maybe tendonitis, or sometimes left shoulder pain may be caused by due to myocardial infarction. So you have to also consider it specifically in old age. Okay. So have you noticed any warmthness of your joint, any redness, any swelling, any stiffness? These four components in any joint. Okay. And then any weakness, numbness, tingling of your joint, of your arm, like it may cause nerve compression, and those may be the symptoms. Any weakness, numbness, tingling of your hand. And to rule out MI, do you have chest pain, any shortness of breath, and any racing of heart, any sweating, like those things? And what are the investigations that you do in arm pain? X-ray, MRI of shoulder joint. Okay. And other than that, arthrocentesis you can do if you suspect there will be some gout or any septic arthritis like things. Other, if not, it is not necessary. And these are the imaging studies are mostly important to rut, like X-ray, MRI of shoulder joint. Other like CBC, differential, electrolyte, ESR, and if you suspect if you suspect osteoporosis, you can also do a DEXA scan, calcium, vitamin D levels. Okay, and let's move towards back pain. What are the causes of back pain? So I've already told you that if patient has back pain, do you have swelling in your back, any stiffness, any redness, any warmthness? You have to ask in all those questions, any joint pain or anything. If there is and then you can go on asking like Socrates, like site onset, character, radiation, aggravating, elevating factors, timing, duration, frequency, and severity scale. So after assessing those questions, if patient has radiation to his legs, if pain is radiating to legs, what is the character of pain? For example, if there is nerve compression, disc herniation, it may be shooting pain, electrical sensation of pain. Okay. Mm, or it may be some fracture in back as well, vertebral fracture may be there. It may be due to spondylosis may be there. It may be due to bone cancer, it may be metastasis, it may be multiple myeloma, it may be just only muscle strain, it may be SLE, it may be rheumatoid arthritis. Okay. So those are the things you should consider. And what questions you should be asked, I have already told you: warmth, numbness, redness, tingling, like those things. Yeah, after asking that, have you noticed any change in your the way you walk, rather than telling have you noticed any change in your gait, because some people may not understand what is gait. Have you any what were you doing when it started? When I was lifting heavy weight, or I was moving some heavy furniture. If it tells that, you suspect that maybe some disc herniation, it may be due to fracture. Okay. And in case of back pain, you should also ask, have you not ever passes urine stool without your knowledge? Okay. Like there may be incomplete bowel bladder incontinence may be there. So, and have you noticed any effect of position on pain? Those are the questions you should ask. And what are the investigations, like you have to do imaging like MRI, X-ray of the lumbosacral spine if it is in the lumbosacral region of pain, and CT, MRI may be needed. And other than that, if you suspect any arthritis, any rheumatoid arthritis, rheumatoid factor, if you suspect SLE, anti-nuclear antibody, anti-dsDNA antibody, like those things. And other general investigation are CBC, differential, ESR, and in old age DEXA scan, calcium, vitamin D level. And let's move towards neck pain. So what are the causes of neck pain? It may be fracture, just like back pain, lower back pain, neck pain may be fracture. It may be osteoarthritis, maybe there may be disc herniation, it may be spondylosis, there may be cancer, there may be metastasis, there may be multiple myeloma, and there may be just only muscle strain, or maybe just ligament tear, those type soft tissue injury, just only that. Or it may be rheumatoid arthritis, or sometimes neck pain may be caused by meningitis as well. If there is neck stiffness, so you have to assess also that. And so in this neck pain as well, you should ask any warmth, redness, swelling. You have noticed any weakness, numbness, tingling of your arm joint, because if there is a disc herniation, it may cause numbness, tingling in arm joint, any weakness of, and any change in your gait, any bowel bladder incontinence, like have you ever passed urine without your knowledge, have you ever passed stool without your knowledge? And what were you doing when you started, like when you are doing any strenuous activities, like any lifting heavy furniture or anything? Or do you have any history of trauma? Have you noticed any trouble breathing? Because it may if there is a cervical lesion, it may cause paralysis of diaphragm. So any trouble breathing? Have you ever noticed any trouble in bright light, to lot meningitis, just photosensitivity? So what are the investigations that you should do? Investigations generally are X-ray, MRI of the back, or CT scan may be required. And other investigations are if you suspect multiple myeloma, serum protein electrophoresis, BU and creatinine. And if you suspect meningitis, lumbar puncture analysis, CBC with differential ESR. Okay. And in old age, osteoporosis, tubular osteoporosis, calcium, vitamin D level, and there may be some autoimmune component as well. If you suspect autoimmune component, rheumatoid factor, ANA, anti-nuclear antibody.